There is a silent and deeply concerning trend unfolding in doctors' offices across the country, a conversation that 91% of physicians are failing to have with their senior patients. It's a conversation about the hidden dangers lurking within the very medical tests designed to keep you safe. What if the routine screenings you're told are for your own good are actually a gateway to unnecessary anxiety, painful procedures, and life-altering complications that could steal the joy and independence from your golden years? For over 2 decades, I've worked as a urologist and senior health specialist, and I've seen the devastating fallout firsthand. I've witnessed vibrant, healthy seniors be pushed onto a medical conveyor belt of tests and treatments that ultimately did more harm than good, all because the standard medical playbook fails to recognize a fundamental truth. After the age of 70, the rules of healthcare must change. This isn't just information, it's a shield. What you are about to discover could be the most important factor in protecting not only your health, but your quality of life. And it's a revelation that the healthcare system is often reluctant to share. The dangerous myth of more is better. The foundation of modern medicine is built on a simple premise: find a problem early, treat it aggressively, and save a life. This model works remarkably well for people in their 40s, 50s, and 60s. But something critical is lost when this same one-size-fits-all protocol is applied to individuals over 70. The medical system rarely pauses to communicate a crucial reality. Medical testing in our later years requires a completely different risk-benefit analysis. A test that might be a lifesaver at 50 can become a catalyst for serious harm at 75. The body's resilience changes. Life expectancy becomes a more significant factor, and the potential for a slow-growing condition to ever cause a real problem diminishes dramatically. Yet patients are often subjected to the same aggressive screening schedules, ignoring the complex truth that for many seniors, intense medical intervention doesn't improve outcomes, it reduces them. We must move away from a mindset of blind compliance and into an era of informed, individualized assessment, where your overall health, your personal priorities, and your quality of life are the guiding principles, not a standardized checklist. 5 routine tests that demand your scrutiny. I am constantly approached by concerned patients and their families, holding a list of tests ordered by their doctor, their minds filled with confusion and worry. A 73-year-old man asks, "My doctor wants me to get a PSA test and a colonoscopy, but I feel fine. Are these really necessary, or could they be harmful at my age?" This question reflects a growing awareness that more medicine isn't always better medicine. Based on 2.5 decades of practice and a mountain of medical evidence, I have identified 5 tests that are routinely overordered for seniors, often leading to a cascade of overdiagnosis, overtreatment, and serious complications. It's time to pull back the curtain on these procedures and arm you with the knowledge to ask the right questions before you consent. 1. The prostate cancer paradox: why the PSA test can be a trap. After 75. This is without a doubt the most commonly overordered test that causes massive preventable harm in elderly men. The United States Preventive Services Task Force, a leading authority on medical screening, explicitly recommends against routine PSA screening for men over the age of 70, and for a very clear reason: the potential harms vastly outweigh any potential benefits. Here is the core truth. Prostate cancer discovered in men over 70 is typically so slow-growing that you are overwhelmingly more likely to pass away peacefully with it than from it. However, a slightly elevated PSA number triggers a terrifying chain reaction. It leads to painful biopsies that carry significant risks of infection, bleeding, and discomfort. If a small, slow-growing cancer is found, it leads to recommendations for aggressive treatments like surgery or radiation, which frequently cause permanent, life-altering side effects like incontinence and erectile dysfunction. You are pushed to endure serious risks and a diminished quality of life to treat a cancer that would almost certainly never have bothered you in your remaining lifespan. A landmark study following over 76,000 men confirmed that for those over 70, PSA screening showed zero benefit in mortality, but caused significant harm through this cycle of overdiagnosis and overtreatment. The question to ask your doctor: given my age and my overall health, what is my realistic life expectancy? Based on that, am I more likely to die with a potential prostate cancer or from it? What are the specific complication rates for the biopsy and treatments you are recommending for a man my age? 2. The colonoscopy question: when screening becomes a high-stakes gamble. While colonoscopy is an incredibly valuable tool for preventing colon cancer in younger and middle-aged adults, its risk-benefit profile shifts dramatically after age 75, especially if you have a history of normal screenings. In elderly patients, the procedure itself carries a significantly higher risk of serious complications. The walls of the colon can become thinner with age, increasing the danger of a perforation, a tear that is a life-threatening medical emergency. The risks of severe bleeding and adverse reactions to anesthesia are 3 to 4 times higher in patients over 75 compared to their younger counterparts. Furthermore, if a polyp is found, the procedures to remove it carry their own set of risks. The American College of Physicians now recommends against routine screening colonoscopies in average-risk adults over 75 who have had prior negative results. The statistical likelihood of discovering a treatable cancer that would actually impact your lifespan is incredibly low, while the immediate risks of the procedure are dangerously high. The question to ask your doctor: since my previous colonoscopies have been normal, what is my actual statistical risk of developing a life-threatening colon cancer in my remaining years? What are the specific complication rates for this procedure at my age? And are there less invasive alternatives we should consider, like advanced stool tests? 3. The mammogram dilemma: protecting quality of life over chasing every shadow. Similar to prostate cancer, the logic behind breast cancer screening changes in very elderly women. Routine mammograms in women over 75 often lead to the overdiagnosis and overtreatment of slow-growing cancers that would never have become a problem during their remaining lifespan. A pivotal study published in a leading medical journal found that while mammography in this age group did detect more cancers, aggressively treating them did not improve survival rates. Instead, it subjected women to surgeries, radiation, and chemotherapy that profoundly reduced their quality of life without extending it. The harm isn't just the anxiety from a false positive. It's the very real physical damage from treating cancers that pose no true threat, causing complications that can sometimes shorten rather than extend a life. The question to ask your doctor: considering my overall health, what is my realistic life expectancy? If a very slow-growing cancer is found, is there strong evidence that treating it will actually help me live longer? Or is it more likely to just reduce my quality of life for the years I have left? The diabetes tightrope, aggressive control, can be a dangerous fall. While managing diabetes is crucial, the pursuit of extremely tight glucose control and HbA1c under 7.0 in frail or elderly patients can cause far more harm than benefit. The primary danger is hypoglycemia, dangerously low blood sugar, which can lead to confusion, dizziness, falls, fractures, and hospitalization. Multiple studies have shockingly shown that aggressively lowering blood sugar in elderly patients with complex health issues can actually increase mortality rather than decrease it. The immediate life-threatening risks of severe hypoglycemia far outweigh any theoretical long-term benefits in a person with a limited life expectancy. Recognizing this, the American Diabetes Association now recommends more relaxed glucose targets for many seniors, an HbA1c between 7.5 and 8.5. Yet many doctors continue to apply the same aggressive targets used for a 40-year-old, placing their elderly patients in needless danger. The question to ask your doctor: Given my age, overall health, and other medical conditions, what is a safe and appropriate glucose target specifically for me? What are the warning signs of hypoglycemia I should look out for? And would a more relaxed blood sugar target actually be safer for my well-being? 5. The imaging cascade, when just checking leads to real harm. It's becoming common for doctors to order routine CT scans, PET scans, or other extensive imaging for elderly patients with vague complaints, or sometimes just to check for cancer. This practice is a Pandora's box of problems. These scans expose patients to significant doses of radiation, and more importantly, they almost always find something. These are called incidentalomas, incidental findings or abnormalities that are clinically insignificant and would never cause a single symptom during a person's remaining life. But once seen on a scan, they trigger a powerful cascade of follow-up tests, invasive biopsies, and unnecessary anxiety. A study found that these incidental findings led to complications from follow-up procedures in nearly a quarter of elderly patients, all with zero improvement in their survival. The question to ask your doctor: what specific symptom are we trying to diagnose with this scan? What is the probability that anything we find would actually change my treatment plan in a way that extends my life or improves its quality? And what is the risk that this scan will uncover incidental findings that lead to a series of more invasive, potentially harmful interventions? A story of wisdom over protocol. Let me share a story that perfectly illustrates this dangerous dynamic. A 78-year-old gentleman came to my office deeply distressed. His primary doctor had ordered a routine PSA test, which came back slightly elevated. This led to a biopsy, which caused a severe infection that put him in the hospital for several days. The biopsy found a low-grade, slow-growing prostate cancer. His urologist, following standard protocol, recommended immediate surgery. When I sat down with him, we had a real conversation. I calculated that, based on his overall health, he had a realistic life expectancy of about 8 to 10 years. The type of cancer he had would likely take 15 to 20 years to cause any problems. He was faced with two paths. Path 1, undergo major surgery, guaranteeing him a final decade spent with incontinence and erectile dysfunction, all to treat a cancer that posed no real threat. Path 2, do nothing but monitor the situation, a strategy known as active surveillance. He chose the second path. Today, he is 83 years old, living a full, active life with his dignity intact. The cancer has not progressed. Had he followed the initial aggressive recommendation, his last years would have been spent in diapers, a victim of a medical system that treated his age as a number, not as a vital piece of his story. Your 3 questions to reclaim. Control. The medical evidence is now overwhelmingly clear. Most medical organizations recommend against routine cancer screenings in adults over 75 with limited life expectancy because the harms consistently outweigh the benefits. Testing must be an individual conversation, not an automatic order. The goal should never be simply to find disease, but to ask, will finding and treating this disease actually improve this person's length or quality of life? You have an absolute right to refuse any test, and it is your right to be an informed partner in your own care. Before you agree to any of these medical tests after the age of 70, I urge you to ask your doctor these 3 empowering questions. 1. What is my realistic life expectancy, considering my overall health, not just my age? If the answer is less than 10 years, most routine cancer screenings are not appropriate. 2. If this test finds something, what would the treatment involve? What are its specific risks and side effects? And how would it impact my daily quality of life? If the treatment risks are high, the test may not be worth the potential discovery. 3. What does the latest medical evidence and guidance from major medical organizations say about this test for someone my age with my specific health status? Demand evidence, not just standard protocol. Nourishing your health. Naturally taking control of your healthcare decisions is a powerful first step. As you wisely question unnecessary interventions, you can also be proactive in supporting your body's inherent vitality. True wellness after 70 is about making informed choices that prioritize your quality of life, not just following protocols that may do more harm than good. You have the power to be the guardian of your own well-being.